I'm so pleased that you asked me to say something about GeriPal and then why I support it. And I'll have to tell you what, in addition to wanting to support my respected and talented colleagues, I appreciate both the commitment to promoting awareness of the intersection of palliative care and geriatrics, and also the way the podcasts provide a greater appreciation of the findings of studies reported in the literature. So they give us a much more dynamic understanding of the findings and the ability to question and ask in-depth ideas around the findings from the research and challenge some of the thinking. So I am just extremely excited to see GeriPal moving forward into 2026.
This episode of the GeriPal podcast is CME eligible.
To claim credit, please go to the CME tab on geripal.org.
Welcome to the GeriPal podcast. This is Eric Widera.
This is Alex Smith.
And Alex, we're going to be doing a podcast on uncertainty in medicine.
Are you sure?
I think so.
I'm not sure.
Yeah.
I think so. Maybe
we should address that
we'll
with our guests. Who do we have on with us?
So we're delighted to welcome John Ilgen, who's an emergency medicine doc and health professions education researcher and vice chair of faculty development and education at the University of Washington and Harborview Medical Centers. John, welcome to the GeriPal podcast.
Great to be here.
And we're delighted to welcome Gurpreet Dhaliwal, who's an internist who studies, writes, and speaks about how doctors think. He is site director of internal medicine clerkship at the San Francisco VA Medical Center and a master clinician educator. I think they both are. Gurpreet, welcome to the GeriPal podcast.
Thanks, guys. Honored to be here, right across campus from you.
And John and Gurpreet both wrote a New England Journal piece on educational strategies to prepare trainees for clinical uncertainty. We thought this would make for a great podcast. But before we go into this topic, we always do a song request. I'm going to roll the dice and say, is it John who has the song request?
Yeah, I'd love for you to start with Should I Say or Should I Go by The Clash.
Why did you pick this song?
Well, it's sort of in the title, but I think there's a lot of indecision going on there, and I thought that would be a good place for us to start, and we can manage that indecision together.
Wonderful.
Darling, you've got to let me know. Should I stay or should I go? And if you say that you are mine, I'll be here till the end of time. So you've got to let me know. Should I stay or should I go? Should I stay or should I go now? Should I stay or should I go now? If I go, there will be trouble. And if I stay, it will be double. So come on and let me know. Should I stay or should I go?
So much uncertainty in that song.
Brilliant.
Thank you. That's a fun choice. Reminds me of like high school.
Yeah.
Yeah,
All
that's 1990s, right? Yep.
All right, I'm going to turn to both of you. I'll start with you, John, first. What got you interested in the topic of uncertainty?
Yeah, well, I think, first of all, I'm an emergency physician, so my work is filled with it. And I think, for me, being an educator, being an education researcher, being a clinician, all those things for me are about intersections. And I think when I've thought about the clinical reasoning literature as I stepped into it, and that's how Gurpreet and I became friends, it always felt very much focused around, frankly, certainty. It was about getting the right answers. It was about making the diagnosis. And I think a lot of those ways that people have represented the ways we think as physicians are really helpful and useful to teach. It felt incomplete to me. And so this was actually the focus of my doctoral work that I started pre-COVID, so 2016 or so. And I've been really lucky to work with some really smart folks that have helped me to really think about these moments of uncertainty and the ways that we navigate through them.
How about you, Gurpreet?
Yeah, same. I am in the same way. John and I were sort of in the clinical reasoning biz, and we collaborate around those ideas. And I think John invited me, so he gets credit for really being the person who was generative and thinking of this. But I love the chance to sort of take a right turn to what I normally focus on, which is like, how do doctors get the right answers, and how do doctors pick the right management strategy? Because it just gave me a sense of stepping back and say, this ER shift I just did this morning was a lot of like, I don't know, I'm kind of in the right ballpark. This seems like the right thing. We're 50-50 on this. And I realized that I had worked up the vocabulary to talk about getting things right. And I hadn't worked up the vocabulary in teaching in particular about how to explain these situations when there is no right answer.
Mm-hmm.
Yeah. And I guess that brings us to the topic of what is uncertainty, because it feels like medicine in general is all about uncertainty. I mean, part of the reason that we went into medicine is if we were certain about everything, A, you wouldn't need doctors, you would just have an algorithm. And B is like, I do a lot of medical interviews for previously med school, internal medicine residency, fellowships. And there's something, especially like in internal medicine, where I do a lot of interviews, is people are attracted to the uncertainty. They like the diagnostic workup. And if there was an uncertainty, maybe they wouldn't be that interested in it. How do you think we should define when we think about uncertainty? What is it? And is it always bad? John, what do you think?
Well, it's a huge topic, as you can imagine. I think Gurpreet and I had to do a fair amount of thinking as we wrote this paper about being clear about what we're talking about, which is really a focus on clinical uncertainty. I think if you start looking into the uncertainty literature, it is so broad, and people are talking past each other in a lot of respects, right? I mean, get from all the way from sort of the philosophical nature of like what is knowledge and what is thinking, what is all these things that we do. So I think in some ways it can be a bit dizzying unless we are a little bit more precise. But I think you raise a good point, which is that, I think there is a gravitational pull towards medicine because it is filled with these complex challenges that we have the opportunity to step into. And I think a lot of times, in my mind, the challenge is the process. It's, it's gratifying to get the answer, but I think the work itself is really, I think where the art of medicine comes from.
So what is then clinical uncertainty? And don't say, Gurpreet, it's just the opposite of clinical certainty.
Can I put it? I have to say first, all right, you gave me a challenge, but I want to ask that point you made first, Eric, about people go to internal medicine because they like the uncertainty. Or, I'm not sure that's the case. Even like picking medicine, I think most of us, when we decide to be doctors, and maybe if you like internal medicine and the Sherlock Holmes, I think it's the opposite. I think you go in thinking like, I'm going to discover things. I'm going to be the person who makes the diagnosis. And oftentimes you say, well, in school, okay, I'm still learning, but man, when I get on the clerkships, I'll learn that that's when they make all the diagnoses. And then the MS3s get on the clerkship and like, wait a minute, like everyone's not sure exactly what's going on with a lot of these cases, but like maybe it's just when I'm a resident. By the time I'm the resident, things will seem certain to me. And then you're like, oh wait, even with this knowledge, I can't figure things out. But you're like, maybe I just need to be a specialist, or I just need to be an attending, and then things will get certain. And then at some point you're like, okay, the gig's up. Like this job is managing uncertainty. So I think for many people, it feels like a switcheroo that you're like, if I can master all this, things will be very certain.
Yeah.
And it dawns on you, it's not going to be.
Yeah. And then, so there's the challenge of I'm guessing for you, Gurpreet, there's this challenge of trying to figure out what the right answer when you start off with uncertainty. But what you've learned over time, it sounds like, is that there's these cases where you still are uncertain at the end of the day. And that's the hard part.
And that's actually the normal ground state. I think that is almost the, again, going from okay, that's an exception to be if I did a shift in the ER today, it's probably 50-50. That might even be generous, but I think 50% of the time I had a sound diagnosis and a very logical singular plan. And the other 50% of the time we did some of the techniques that we'll talk about a little later, like teaching just to keep an eye on things and to forward monitor and accept this is the best we can do right now. So I've really enjoyed sort of saying that actually a lot of our cases on this shift in clinic or the ER on the wards are going to end like that instead of a final diagnosis and the final plan.
And then I'm going to go back to this question because I'm still uncertain about it. When you said clinical uncertainty, we're not going to be talking about the bigger, what is truth and all of that. We're going to talk about clinical uncertainty. What do you mean by that?
Yeah, I think that's a fair question. I think that just gets down to instead of all these philosophical things, they get down to the professional judgments we're supposed to do, which is what is going on with this patient and what should I do? I think John and I talked about those two being so useful questions if you're really saying, am I having a moment of clinical certainty, they are often, what is going on or what should I do? And I think, you can make those more intellectual, but those are the root feelings you're in a clinically uncertain moment because those pertain to the patient in front of you.
And that kind of highlights like the three, I'm going to say 3 pillars of medicine. There's the diagnosis, there's the treatments that we have to offer, the what should we do, and then there's also prognosis that kind of permeates through everything too, which I'd love to talk about too, because that's where a lot of our work around uncertainty falls into play. How do providers usually react to uncertainty?
I will say that typically the representation of uncertainty has been very negative in most of the literature about, it's about reducing uncertainty. It's about the ways in which uncertainty causes, X, Y, or Z, burnout, fatigue, all these sorts of things. And I think, certainly as sort of a holistic experience, no one likes to feel uncertain all of the time. But I would argue that uncertainty is really useful to us. It's a place that tells us sort of the edge where we should be working, and those sort of questions that come up in the care of a patient, where you have to make a decision even though you're not certain. And that's, I think, in a lot of different contexts, the way that doctors work, to me, is where actually a lot of the enjoyment in medicine comes from. So I think kind of leaning into that feeling or perception of, gosh, I'm not really sure how to put this entirely together, but I think I'm pretty close to being on the right track. And for me, it's someone used this analogy of walking down a dark path. The idea that you're not exactly sure where you're going, but you can tell that you're on the path. For the most part, you can look down at your feet and see the ground beneath you, et cetera. You may not be exactly sure on what's on either side or what's in front of you. But I think over time, you get these skills to sort of learn how to do that safely and effectively.
I would agree. I've had a bit of a positive spin on uncertainty from this whole process, which is, I used to think of it as sort of like, a disappointing end of the journey. And now, when I'm with a learner, I'm kind of like, this is great. We're uncertain. This is an opportunity to learn. I'm by myself. I'm like, there's some edge here I have to figure out, or a strategy I've never devised before. So normalizing it, by studying it and sort of normalizing it, you just recognize your reaction to it. You're a little bit in control how you react to uncertainty. Because it's ever present. You can even practice getting better at it and sort of enjoying it.
Mm-hmm. Yeah, I just want to reiterate something you said just a moment ago, and also was in your article prominently, is that our education system, particularly medical education system, is really structured around this idea that certainty is good and uncertainty is to be diminished and avoided and eliminated. And those, M&Ms that are most successful are when the master clinician wades through all of this uncertainty and then arrives at the correct diagnosis, right? Same thing with those New England Journal of Medicine, like CPC reports. I wonder, so what you're talking about here is like really fundamental, a challenge to the way in which we teach about like all of medicine, that maybe so much of what we do is uncertain and does not end in a certain diagnosis. And how do we restructure our educational system to make people more comfortable with the fact that uncertainty is just a part of our clinical reality?
Yeah, I love that question. I would say, in writing that, we recognize all the places like uncertainty is sort of, we're forced into it. It's like billing platforms, the EMR, taking our tests, answering questions on rounds.
You got to put those ICD-10s in there.
Yeah, you got to get them just right.
There's no is there an uncertainty ICD-10? No.
It's between X and Y.
That's diagnosis. It's like at the eye doctor. Is it better or worse if they switch?
Oh, God, I hate that.
That's what it's like. But I will say as a counterpoint, even though we're sort of here as the uncertainty fan, is early in medical training, you probably do have to lean in on certainty, right? If you open up on day one of med school, be like, yeah, we don't know what's going on. Or, you have to give some ground knowledge and test that. So the question probably is just how soon do we introduce people to the idea that, that things are not as clear cut and things are uncertain, and this is what professionals do. So I don't want to say it's bad to have a test early on in school where you have to get the right answer, or a professor asks you something and there's foundational knowledge to know, but we probably need to do it much earlier than we do.
Well, I got a question about that then. Like, is the idea of certainty a self-delusion that we train into physicians and other healthcare providers? Because we're never really 100% certain, right? There's just degrees of uncertainty that we're dealing with. Even if you come up with diagnosis, you may be proven wrong later. Even if you have a good diagnosis, the number needed treats of any of our interventions are never 1.
Yeah.
Maybe they're 4, maybe they're 10, maybe they're 100. So odds are your intervention's probably not going to work in that individual. And then we're dealing with like prognosis, which is inherently also uncertain. So is this all just a self-delusion around certainty?
Yeah, I mean, I think you raise again, we're going to get ourselves very much into philosophy.
Sounds like philosophy class. Exactly. I was going to bring up my philosophy.
Does truth even exist? But I will say, I mean, we have to have some footholds, right? I mean, nobody wants to go to the doctor and for them to respond, it could be anything each time you get there, right? And for the same reason, we can't go through our whole day wondering about every possibility of the things we see around us, recognizing that everything is a perception, right? So I think, in my mind, a lot of the way that this work has trained me to think is to just have a much more tentative hold on the things that I think that I know. And the idea of kind of regularly revisiting it, using people around me as resources to see if they're coming upon the same kinds of understanding of a situation. And for me, I think it's really made me think much more about the ways we sit in the nexus of a collaborative system, right? We've got other health professionals, we've got families, we've got patients, we've got all these people who are trying to make sense of a situation. And there may not be an absolute truth there, but it's our best working hypothesis in this moment that enables us to take a step forward. And I think that's, to me, it's you have enough certainty to activate something. You're never 100% certain, but it's enough of a certainty to know that you can try something safely, and then you're watching to see what happens.
And I love this idea of triangulating, because you wrote about this in your New England Journal paper, where you're using patients' families, interprofessional team members, like the respiratory therapist. They look anxious. They're visiting this person more often. Even if I'm feeling pretty certain, I wonder if I should rethink where my certainty level rises, or wonder, why is this happening? Am I getting that correct?
Yeah, I'll leave it. I think like part of it, and I think John really has looked into the professional aspects of this, is like when we were working on this project, I realized how many of our cues come from outside sort of the pure medical facts. It is everything from, how fast the heart rate is going to what's the expression on the nurses or respiratory therapist's face. And sometimes our obligation to trainees is to explain, like, I actually feel pretty calm about this because this experienced respiratory therapist is also very calm about this. And, this nurse knows the patient really well. And even though I have some uncertainty, I'm using those clues, or it can be completely inverted.
Yeah.
John, I wonder if you could talk about this, Gurpreet's got a visual here. You got to explain it for our listeners.
I know we went super philosophical, but I just want to say, I think someone was saying that about, I think it was Alex, like, well, it could be anything, and no one wants to have their doctor say that. Maybe John was. It reminded me, there's this New Yorker cartoon from 2005. I have it in my clipboard. So you don't have to trust me, but just a guy looking at someone's ears, and it's called The Way to General Practitioner. He just says, could be anything. We're definitely not trying to get that.
And Gurpreet, I have the same cartoon on my refrigerator at my home. So
it's a good one. Yeah. If we run out of material, I have a stack of New Yorker cartoons. Just let me know. If we have to do like if premium subscribers need like a bonus content, at the end we'll run through them.
John, I wanted to ask you, your article is largely directed around medical education and teaching. And one of the key things that you point out is that trainees often have this sense of, something's not right here. I'm really worried. And they also have this sense of, I'm a learner. I'm new to this. I'm distressed. I shouldn't know anything. I don't know what to do with these feelings. Am I a bad learner if I acknowledge that I don't know? And so how do you help learners sort out this like complex mix of emotions and feelings when some of those signals may be important clues that what they think is the diagnosis may not be the correct diagnosis, and when they're in this, new state of learning?
Yeah, I mean, a lot of the things that we're talking about these in-the-moment reactions that we're alluding to here, really draws from this field of self-regulation, this idea of sort of having cues that come towards us, assimilating those cues into appraisals of a situation, and trying to make sense of what is going on and what you might do. And so I will just say that one of the interesting things when we looked at this in trainees in some of my doctoral work is it is so messy for them because they are so skeptical of their ability to accurately assimilate, and their own abilities just more generally. So even when their cue was actually very appropriate, they distrusted it. This worry that they had for a patient. Well, I must be just worried because I'm learning, or am I worried because there's actually something wrong here? And that idea of kind of supporting trainees in that experience is really tricky, I think. And I think, I think in many ways trainees want to feel this sense of authenticity and independence in their work. And at the same time, they're not always sure when they need that support. And it's sort of us kind of gauging that dance of certainty, uncertainty. Am I appropriately regulating or not? So I think, to me, a lot of this that we talk about in the paper, and I think a lot of the discussions we've had, is we have to draw them out. I think doing some of that guided exploration of, how are you doing right now? What are you worried about? What are you seeing? What are you paying attention to? Or here's what I'm seeing, and I completely agree with you. You should be worried here. Or here's some things that give me more comfort. Having seen this before, I can understand why this is giving you some pause, but here's all the things that are giving me a lot of reassurance. And so I think we're in a safe place. I think some of that unpacking, recognizing that, we are not a gold standard. We are just, we're just the best that they have in that moment, right? Our impressions might be incorrect, actually. The trainee may be picking up on something that we are minimizing when they are absolutely appropriately worried and we're not. So I think there's some humility on our end as well, but I think a lot of that call and respond, talking out the things that are going on in our mind, including our feelings, which I think is something we don't talk very often about, but that sense, that spidey sense of, gosh, something doesn't feel right here, or something's making me nervous, or gosh, I feel really good about how we're doing here. Those things we rarely say out loud, but it's absolutely guiding how we move through these complex moments.
Do you think we should say it out loud more often, even without trainees there? It seems like a good mindfulness practice to say, I wonder what's making me worried right now, and asking those exact same questions even without trainees.
Yeah, I'll be honest. I use those words strategically. And, as an emergency doc, I'm upstream of virtually everybody who I end up speaking to in the hospital. And I will use those words. I'm worried about this person. I'm not sure what's going on, but something is not right with this person, right? I really want you to pay attention and help think through this together, because I'm feeling like things may go south here, right? So I think some of this is some vulnerability and humility to say to these, the folks who are going to be inheriting patients from me, I want them to really intensely monitor a situation differently than maybe every other admission I called them about that day. So I think some of that stuff is it's not a social norm. We don't talk about our feelings very often, but I think in the right context, we should. Sometimes we can't put words to the things that we're seeing. And I think the worry that we have is that, we call it a diagnosis, we simplify things for people, but we ignore all the messiness around it. I may say there's this diagnosis, but I actually don't really believe it. Or there's a big differential that's still around that diagnosis.
Mm-hmm. And I would jump in. I agree with that idea that the skill, and maybe it's like the core skill from the article, is like the ability to narrate. I think, John, you said either call it out or narrate it out, but either you're expressing it, or maybe more, I'm trying to see the learners expressing it. And then trying to say, well, we can't leave it at that. Like, I get the sense they're uncertain, they use some words or body language, something like that. But I think for me to move forward, to turn into a teaching experience, like one of the things is I have to pinpoint it somewhere, and I might start to break it down. Like, is your uncertainty around the diagnosis? Is it around management? Is it around some ethical quandary? Is it that you don't think the health system's going to come through in this situation? Is there an interpersonal thing, like calling the consult will be premature or seem unfounded? So I have really tried now, once I sense uncertainty, to sort of pinpoint where it may lie, because it can lie a lot of places in healthcare, way beyond DX and RX, actually, given how complex it is. And then if I can say it, the learner will be like, oh, no, I'm not worried about calling the consultant. I actually was really wondering whether we were doing this system is going to deliver it. He's going to get the appointment or not.
Do you use the words epistemic and aleatoric with your trainees?
Alex and I had great uncertainty over those words.
We both looked them up.
Mainly how
to have confidence that I know what they mean.
Or how to pronounce them.
Yes.
I'm guilty as charged. We promised this wasn't going to be a philosophy class, but I do love because the other way, once you outline where it is, diagnosis, system, whatever, the next thing is if you are so inclined, is you can try. It's not clean. It's not easy in the real world, but is it epistemic or aleatoric?
Aleatoric.
Aleatoric.
Yeah.
Okay, now you have to define. Okay, what is aleatoric?
This is like a spelling bee. Can I use it to say the word of origin? Though I do know the origin may help. Epistemic comes from the Greek word for knowledge, episteme. The other one, aleatoric, if I'm pronouncing it correctly, I do not know exactly its etymology, but it comes from a Latin word that's roughly around like dice and gambling, etc. So they do give you two senses. Epistemic is like literally the knowledge is not present in this moment to move forward with it, and so I'm uncertain. And I think that can live in a lot of places. Like I don't know it, or no one here at the San Francisco VA doesn't know it, or all of science doesn't know it. And then aleatoric is more like it's a random thing. Like I just don't know today if I give Septra to this person, will they get a rash? If I put in the referral for this general surgery clinic follow-up, will it happen in the next month or so? Like there are some things in biology and health systems that are truly unknowable and unpredictable. And they do give a little bit of strategy. If you don't know it, if it's epistemic, there's a chance to go search for information. But if it's aleatoric, oftentimes there's nothing you can do. You cannot reduce the uncertainty anymore. So it's sort of like potentially reducible and irreducible uncertainty.
And it's probably both, like, right? Because for most people, you never know 100% sure what's going to happen. Like you can't, accurately predict the allergy to the drug that you're going to give.
Yeah.
But then there's also like you have older adults with multimorbidity. Like there's a lot going on with those patients. And like, can you apply what you've learned from this randomized controlled trial that you just looked up to this patient that's sitting in front of you, going from population to individual?
Yeah.
Which is also impossible.
Knowledge doesn't resolve on uncertainty. That's all uncertainty. That's absolutely right. And this epistemic and aleatoric, I agree. At some points, you're like, well, there's a little bit of both in this. It just more as a lean into the strategy. If it's potentially reducible, sometimes I just have to find the knowledge.
Yeah.
It could be an up-to-date. It could be an open evidence. It could be my professor down the hall or my colleague on the phone.
That is the funny thing with uncertainty, right? It is independent of knowledge or information. You can actually get more uncertain by looking stuff up. You get in this.
It's so true. One of the things we reflected on, I think we just had a single line on it in the paper, but it's really important is that we sometimes think technology resolves uncertainty.
Oh, yeah.
But it really just, it solves some problems and it creates new ones. It sort of, it shifts the uncertainty frontier to something else. This morning, we had a patient who came in, he was referred from clinic, and he had swelling right under his submandibular swelling. Clinically, it seemed all the world like a acute sialadenitis, like a single day something blew up right under my jaw and it's tender and painful. It sounds very much like it. And we almost could have called it a wrap and given him some lemon drops. But the PMD who knows him said astutely, the only thing is he has Alzheimer's, and I'm not certain if he really is clear that it's been a day or not. He's very elderly. It's he's sort of declining. Is this the harbinger of a cancer or something else? So we did the CT scan. This is fresh, and the CT scan said, to me it looks like a lymph node, but I'm not sure. And so they were worried that this thing is a lymph node, not the salivary gland, I thought. So all of a sudden, the CT scan, which we thought was going to reduce uncertainty and either clearly tell us it's a lymph node and we have a pathway, or clearly tell us it's a swollen salivary gland. Now we just have a lot of information that we have to deal with, and I'm not certain we've done him any favor. We're still going to treat him like acute sialadenitis because it sounds like it, but the technology actually added uncertainty. It did not resolve it. And so me and the resident had to work on the skill of resolving it.
Right. Recommend MRI, PET CT, and biopsy. Yes.
I'm very afraid of the cascade we set off, right? And if the CT scanner was broken or it was the middle of the night, we may have never subjected him to this.
Right.
Yeah.
John.
I think, to me it is helpful to classify uncertainty as we're trying to do here, and the many different, naming all these different types of uncertainties that we encounter. And in some ways, exactly what Gurpreet just described is medicine, right? One uncertainty begets another uncertatainty. And so I think in a lot of ways, I think that the approach we're advocating for is not necessarily that you have to elaborate and name every uncertainty that is present. And then you can imagine that if you're in a team, each of those team members have a whole different litany of uncertainties that are all affecting there. I think in the end, you have to do something, right? This is what the work of medicine is, right? And so I think, regardless of whatever those things are classified as, I think a lot of this is about thinking ahead. What might happen here? What do we need to prepare for? Maybe there's some inherent aleatoric randomness that we have to just be ready for. And then what are we going to do to monitor it as these things go forward so that we make sure that we're on the path, or we're making sure that those complications that we're worried about aren't happening. We can catch them early, those sorts of things. So I think, in some ways it can be just kind of overwhelming to think about a million layers of uncertainty.
Yeah.
To me, it comes back to like managing the experience is actually what we care about most. It's sort of being deliberate about the ways in which we plan ahead and monitor in parallel with each other.
I think it shows that there's no superpower to managing uncertainty. Like, we just have these set behaviors we do. So a trainee may look at an attending and be like, oh, they're managing it so well. But we can tell them, like, these are the only two things. We either, we sort of plan, we monitor, we gather information, and that's it. That's the way we practice medicine.
Well, let me ask you this, because you brought it up briefly in your article. You can think of uncertainty as a state, like I feel uncertain about what's going on here. But you also mentioned this as a potential trait when we think about the learners, ourselves, when we think about uncertainty. Can you describe what you meant by trait?
Sure. I mean, I think some of this is the ways people have talked about uncertainty, which is like a trait. There's a literature on uncertainty tolerance, which is largely drawn from people's responses to hypotheticals. So you'll give them a scale that says, I like it when my day, I know what's going to happen in my day when I go to work, or I really enjoy the challenge of not knowing, and depending on people's responses, you can create a profile, and then you can correlate that profile with other things, burnout, wellness, whatever you want to do. And those, again, are sort of personality traits or sort of more holistic experiences. But, a person who could be very uncertain tolerant, let's say, you put them in one context, they're going to look very different than a person and that same person in a different context, right? Imagine an orthopedic surgeon showing up to sports clinic and doing their work around people with knee problems, and then a woman in labor showing up at their clinic, right? That experience of uncertainty around that patient is going to be vastly different than every other orthopedic-related complaint. And so I think for us, there's probably there's some learned behaviors that we get more comfortable with over time. I've finished residency in 2008. Like, I think differently now as an attending, and I know that there's enough uncertainty in my work that I'm never going to completely know. Throughout every shift, there's going to be some of these moments. That's probably a bit of a trait at this point, but it's based on a lot of experiences where I had to be in these states of uncertainty and figure my way out of them. So my sense is probably the most useful parts of this article are thinking about this as a state. And this is a moment in practice where you have to sort of realize you're in this place, pay attention to the things around you, use the resources that you have available to you, and try to work your way forward to the best of your ability.
And it kind of makes you skeptical of the idea. I think that, like, people with certain uncertainty tolerances pick certain specialties, or...
I was going to ask that. Like, it seems like in ED world, you have a lot of uncertainty because...
But you have the joy. I think you also... Here's my take. I love your thoughts on my take. Feel free to disagree. Emergency medicine, like, you have the opportunity to winnow down the uncertainty. Like Gurpreet said, like, by the time he's done seeing a patient in the emergency department, like, half the time he's figured out a diagnosis, pretty certain about it. But the other half of the time, not certain. But that's a tremendous amount of winnowing down the uncertainty. My sense is in geriatrics and palliative care, speaking to our audience here who take care of people with serious illness or people who are older, there's less diagnostic uncertainty. Like, so often the patients we see, like, they're hospitalized for their 4th heart failure exacerbation in the last year. The diagnosis is clear, right? Or they have cancer pain and it's exacerbated and they need an admission, in order to manage their pain. My take is that there's less diagnostic uncertainty in the practice of geriatrics and palliative care, and that the greater uncertainty is more about, like, how do we manage this, treat it, and then, like, where do they go from here? Are they able to get back home? Should we be considering, talking about prognosis, thinking about hospice? And that's where more of the uncertainty comes in and not so much in the diagnosis. And I wonder, this is my point of this, is if our medical training is directed too much towards the diagnostic certainty-uncertainty question, when in reality, the practice of medicine, for most of us who aren't in the ED, is much more around the treatment prognosis end of the spectrum than it is the diagnosis.
I'll give a brief answer because I think John studied this, particularly with diagnostic labels. I think you characterized ED really well, the way I haven't thought about it. I think that half the patients, we just bring the full force of the ED's technology and team, and like we at least put it in a box. And then the other half of the time, we are left with a syndromic thing that we, sort of leave to the rest of the healthcare system. So I want to, before I turn it over to John, I just wanted to say I think that was a very clear characterization of a lot of ED. And it could make you understand why some people would or wouldn't be attracted to ED, but both of those things are present in the practice.
Yeah, I mean, it's funny, Alex. Your reflection has made me remember something I've said to multiple people, which is that if I was an emergency medicine doc, I think I would have wanted to be a palliative care doc, which may be sort of strange for you to hear, but I think actually it's the exploration that I think is really interesting. And I think in a context where perhaps a diagnosis is known, but actually what you do with that and how you help somebody walk through it is where the work is. I also find to be incredibly interesting and meaningful, right? I think some of that is the part of the challenge that at least we heard in some of our participants in our studies is when the patients weren't able to tell them what mattered to them, that's actually that moral uncertainty of what is the right thing for this person who can't actually say what they would want in this context, that caused more distress than almost anything else. And I think what's interesting to me is to think about, the ways in which we are partners with patients. There's obviously power there, but that sort of idea of like, are you certain enough? Is my certainty enough for this patient in this moment? Or does this person really need us to do some more workup to make them feel better, not so much necessarily to make a diagnosis? We've done some work with some primary care doctors, and what's really interesting about that is these doctors, largely in an effort to preserve their relationships with these longitudinal, patients that they've had, will do all sorts of things diagnostically that are really about palliating symptoms. So they'll order a stress test in a 25-year-old, primarily because they're so worried about the chest pain that they're having because their father died of a heart attack, that actually, even though they know that test is a useless test, it's very useful for the purposes of palliating their symptoms and making them feel better and moving through the world. And so I think there's a lot of gray here. We talk about these things as sort of diagnosis or not. I think there's a lot more messiness around how we use some of these things to make people feel better, which is ultimately, Gurpreet knows I love this paper by Arthur Kleinman. It talks about the distinction between disease and illness, illness being the thing that people experience. And I think a lot of this management of uncertainty is all about the illness experience. What would this person want? Is this aligned with their goals? Do we have to fully differentiate this problem now, or can we kick the can down the road a little bit because they don't really need to know that with certainty at this point? So,
yeah,
that's great.
I
would
love
even say some ED testing we sometimes do for the patient. I mean, even in that short time scale, sometimes we're going to do this because this test will be healing. Not that it's not the doctor's uncertainty, but it's the patient's. And I agree, that's worthwhile use of resources.
Yeah. And I loved what you said because it ended with a lot of questions. And I can imagine from a learner's perspective that starts increasing your heart rate as there are so many uncertainties as you think about this. One line that I really liked from your paper was that we need to reframe uncertainty as a central feature of how clinical problems are understood and managed. And I loved your paper because it had beautiful tables around this. But if you can give our listeners some idea of how do we actually do that? How do we reframe this? And then when you acknowledge that uncertainty is happening, how do you walk people through kind of what we should be doing? And how do you train it?
Gurpreet, you want to take a stab?
That was a very prophetic statement. I think John wrote it, but I'll opine on it. I just think, it's sort of like I said, instead of making it, or I didn't say, but as I'm thinking is instead of making it an apologetic ending to our conversation we're having around the case, et cetera, almost like pre-advertising, like, we're starting this case, we're on this journey, recognizing that part of the end is going to have uncertainty, part of our conversation is going to be uncertainty. Again, I'm prone to unpack it a little bit and try to find out where it is and whether it's reducible or not. So I might be guilty of trying to put it in a box, but sort of featuring pretty early on, like we're heading towards uncertainty, and that's going to be a big part of how we go through this case, rather than a whoopsie daisy, that's how it ended, and we're in uncertainty.
Yeah. And it's often easier to say what something isn't than something that it is, right? And so I think some of the times when I'm talking about this with patients, it's, so glad that you came in for this. Here are some things that we've done that make it seem that it is not these other worrisome things. I'm still not sure what this is, but I think you're at a really safe point to get to the next step, which is to go, follow up with so-and-so or whatever it might be. So I think some of that is, again, I think there's some humility in the ways in which we represent what we do. I think truth is hard to get to, and yet that is what patients expect. They want the truth, and nothing but the truth. And I think a lot of times just representing, this looks like this, that we're going to take this next step forward, and then we're going to get you some follow-up to make sure that we're on the right track. And I think that, this, the example I think I've used before in some papers is sort of this idea of no one gets treated for granulomatosis on the first try, right? They're often treated for pneumonia first because the infiltrate on X-ray looks like a pneumonia. And yet when they don't get better and now they're back with an ear pain and some sinus congestion, okay, well, we're going to keep working on this, right? I think what patients want is to feel cared for. And I think this idea of, we've tried something, it hasn't gotten better. All right, let's revisit again and try some more, I think is, to me, closer to what we actually do with diagnosis as a process.
Yeah.
If I can add in conferences too, I'm at a lot of teaching conferences, and I think in the past we'd say like, oh man, they didn't have a clear final diagnosis, or it's just a humdinger. They didn't know what's going on. And now I found myself sort of saying like, thank you for presenting that case. It's awesome. We don't know if this is gout or septic joint, and this is what doctors do in this situation. Or, it wasn't clear if he needed that perc Foley tube because it was questionable cholecystitis. And I really appreciate you showing us how you manage that situation. And I think, if teachers start saying like, this is the art, is like learning from our colleagues how they manage uncertain situations. That is as good as saying like on hospital day 3, the path slide came back, and for hospital day 30 and the diagnosis was revealed.
Yeah.
Can I share something that Gurpreet taught me a while ago to put you on the spot, Gurpreet? We haven't talked about this.
I hope it was good.
but one of the things I think there is, we use retrospectroscopes a lot in medicine. That idea of, we got to this diagnosis and then look at all these great steps that I took to get to this sort of magical diagnosis where the clouds opened and the angels sang, et cetera. One of the things Gurpreet taught me years ago was that when he reads the case reports of the New England Journal, he reads them with a piece of paper over the remainder of the text. So he does them line by line. And so you read a case evolving and think, what would I do in this context, given the information that I know, which may just be one sentence. And now I've got 2 sentences. All right, how is my thinking evolving? That's much closer to what we actually do in medicine, as opposed to sort of beautifully reconstructing this perfect path towards this esoteric diagnosis that most of us, won't get on our first try. And so to me, I think representing that evolution in our case conferences and actually celebrating this hard work that we do when we don't know is a really important advance, I think, in our field. I think most of us love the dopamine rush of the right answer, but the reality is that most of the work that we're doing is in the context of not having that answer. And so we should celebrate that work.
Can I also briefly share this, a little bit of a side, but at least it's related to teaching, something that Gurpreet taught me when I was starting. I think actually when I was new faculty, you were part of the new faculty orientation on my day.
Right. That tracks.
And you said, one of the things that you start off with in every in lectures, and that I use in most of my lectures now, is to acknowledge that if you're in front of the room giving a lecture, like you said to us, like, I am up here as a so-called expert, but the expertise in the room is greater than my expertise. And I would love to hear from you about blah, blah, blah. I use that. Like, I use that almost every time I give a talk, because that comes back to that approach of humility that you talked about earlier. All right, kicking it back to the topic.
I got a
Eric.
question, because we're running out of time. I got to ask,
Appreciate that.
how do you train others how to communicate uncertainty to the patients, the caregivers?
Yeah.
How do you do that in your own practice?
I think that might actually be the biggest challenge of all, even though we spent the majority of our paper and the majority of our cognitive effort on teaching, ourselves and trainees. I still think the greatest challenge is conveying it to patients, because there's no one formula. There are interesting papers. I think we cited one where they tried to do 3 different approaches with families. I think it was in a pediatric setting, but one was like, essentially, we don't know what's going on. One was giving them a long, exhaustive differential diagnosis. And one, which I think families preferred, was we're not 100% certain, but this is our leading idea. And that played well in, I forget, whatever assessment way they used with patients. I probably lean towards something like that. I think the idea of someone coming to a professional and them coming back with their arms completely up in the air might be a little bit unsettling. So I think I always try to share with, this is my leading thought. But this is, it's clear that we don't know what's going on. I think the thing I have to do after that is say, like, is this how we're going to keep track of it going forward?
Yeah.
I would just add that we rarely ask patients what they think is going on. So that idea of attribution to me is a great starting point. Hearing what they're worried about, hearing what they're thinking about. We may have actually quite a bit of certainty around actually the things they were worried about that brought them to the hospital. So I think eliciting those perspectives is important. We talk a bit in the paper about teach back. I do think that that's really important. This idea of here's what I've said, what did you hear and what is your understanding? I will say, having just navigated some medical stuff with my parents, it's really hard, even as a healthcare provider watching this happen, to watch what we do in medicine. We spend so little time with patients.
Yeah.
It's so fast. So the idea of trying to do teach backs and trying to do all these things we talk about, or really trying to make sure they understand, you're going to bump into a lot of the limitations of our healthcare system very quickly, where we're a limited resource, and there's just a lot of time to navigate this. Think about other professionals helping us and working together collaboratively, and some other resources we can draw upon.
The funny thing is, and like we think about, again, like diagnosis and treatment, we are very uncomfortable acknowledging uncertainty when talking with patients. Weirdly, though, when we talk about prognosis, the number one response I hear from providers is a true acknowledgement of uncertainty. Yeah. We don't have a crystal ball. Doctors don't know that. That's the first response. It's like polar opposite of this tension with uncertainty. Any thoughts on that?
But is that maybe because that allows you to give hope, right? Like that leaves it open-ended.
That's why.
In a way, when people are trying to, close on a diagnosis or close on what med I should have, I think that openness works in our favor.
But that's the funny thing about uncertainty, right? Like, it's not always something you don't desire. Sometimes it's something that you crave. Like, you will actively try to seek uncertainty. If the doctors are telling you have cancer, you're going to probably try to figure out, like, could it be something else? You want uncertainty in that case, just like the bad prognostic estimate. Maybe you want it. But like what John said earlier, is that patients deserve to know. They want to know.
Yeah. But I think it underscores that uncertainty is not always bad, right? It's not always bad for patients, and it's definitely not bad for learners. If anything, it's great. Yeah. It's an opportunity to learn.
Okay, lightning round. If you had a magic wand, you can have healthcare providers do one thing different when it comes to uncertainty. What would you use that on, John?
I would have a magic wand to freeze time and enable people to really get into it with each other and explore each other's perspectives. I think if we had more time to elicit the strengths around us, to your point, Alex, about having a group of smart people in a room, I think sometimes we're just limited in the amount of perspective taking we can take. But I would just say that, like, if you could freeze time and really get the best of everybody around you, I think we'd do a lot better.
Wonderful. Gurpreet?
If I love time, but if I didn't, just one-on-one, I'd tell my learner, every case is uncertainty. Give me your uncertainty, name it, frame it, and then we'll talk about how we're going to manage it.
Yeah. And I love that. I think it was in your paper, like maybe even grading uncertainty. Maybe it was another paper I read. Grading uncertainty. Like, think about how uncertain you are, like very low, very high, instead of always getting this idea, that we have to be certain. We have to come up with a solution. Yeah. Alex, anything for you?
What's the question?
Yeah, he's uncertain about the question. How about you sing us a little bit more of Should I Stay or Should I Go at the end of the podcast?
Should I stay or should I go now? Should I stay or should I go now? If I go, there will be trouble. If I stay, it will be double. So come on and let me know. Should I stay or should I go?
We should go because it's the end of the podcast. But before we do, Gurpreet, John, thank you for coming on this podcast.
It's a pleasure.
It was a blast. Thank you, guys.
And to all of our listeners, thank you for your continued support. And we'd like to do a special thank you shout out to all of our donors who've donated more than $250, including Alex, who?
Kate Mesrich, Jen Hopping, S. Ashad Abid, Michael Bordowski, Harry Hahn, Carol Heyman, Gretchen Schwarzy, Sharon Brangman, Elizabeth Chung, Paul Amatelli, Brian Cassell, Victoria Brand, Susan and John McFadden, Christopher Heck, Emise Simoji, Matthew Schuster, Karen Hagan, Lloyd Woolstat, Carrie Levy, Marmy Fetzer, Ron Sabar, Stephanie Gabatuller, Patrick Lally, Richard Lewis, Margaret Leung, Cindy Harris in honor of Emily Guillot, April Sear, Anand Nayak, Xin Yi Wang, Sudha Chandrasekhar, Michelle Reisner, Asher Edwards, and Susan Nelson.
And thank you for your support again.